My name is Kwame Owilo. I work at the Institute of Economic Affairs as the Chief Executive Officer, and I welcome you to our meeting today. Today is the 24th of November 2022, and we have put together a webinar to discuss an important, if altogether insufficiently appreciated problem in Kenya regarding non-communicable diseases more generally, but specifically chronic kidney disease. And we are trying to harness perspectives from a variety of professionals. So today we have, as your program shows, we have an experience or somebody who's living and undergoing treatment with renal disease in Kenya. His name is Kennedy Jejo. And then we'll listen from a nephrologist or the professionals who take care of patients. But because we were concerned about typically concerned about Kennedy is in Kisumu, and we were concerned about connectivity and the strength of the internet. We asked him to record the message. He's available, but we asked him to record his presentation, which will take 20 minutes. And so I'll ask my colleagues to play it now. But in the meantime, I'll ask all of you to please keep your cameras shut, and keep your cameras shut and your microphones muted, so that we can have this presentation. So here it is, just as peaceful.
I'm a renal patient currently based in Kisumu, and I would take this opportunity to share a brief about my story and also delve into the discussion of the day on kidney donation regime in the country. So I trace my story from the year 2019. And I think it all began normally, like it would happen to any patient, feeling headache, getting over-the-counter medication, back and forth. Sometimes being diagnosed for malaria, you go take medication, you feel well, you get back to your routine life. So I went through this for a period of time. I think a lot of it was routine headache that later I came to realize were situations of hypertension, symptoms of hypertension. So I would routinely self-medicate, get some painkillers here and there. Sometimes I think get to a point where now I was using Betapin, a strong painkiller just to feel better, but I was keeping in a problem that I didn't know at the moment. So this went for some time until I think mid-2019, when I think on two separate occasions, I think I collapsed, one in town, the other one while I was in the house, and got admitted. And I stayed in the hospital for around 3 to 4 days on both occasions. And I think I was hypertensive upon admission, and I think I was put on some medication to balance me off. And I think after some time I was back to my routine life, normal things, twice. Until on a separate day, now other things were coming in. I was feeling a bit unwell most of the times, sometimes getting dizzy, sometimes there's so much sweat and so much that was happening that I was unable to explain. So I took an opportunity one time to see a specialist who requested that I put together all my previous hospital records so that he could study them and really find out what could be the problem. So he looked through and he told me there could be something that I think is here that was not looked into. So from the test results alone, he was able to say, I think you could be having some underlying condition that I think has not been discovered in all this period. And on asking for further tests, I think then he was able to finally evaluate all these results and come to a conclusion that I had a problem somewhere, and most likely with my kidneys. That was what was putting me, predisposing me to hypertension. Because as commonly known, I think a lot of cases of kidney conditions would either come from somebody who's either diabetic or hypertensive, or maybe somebody who's overweight, but I didn't present all these conditions before. So then I think then the trigger was that my kidney problem is what was now making all these other things now expressing as symptoms that I was now suffering. So I think this now took me to the next stage where I need now to do something about this, and the reality of now thinking of a treatment program that could see if my kidneys could be made better or supported to work better. And this started late in 2016, 2019, all to mid 2020, where I was put through a series of medication just to see if this could get better. But it didn't improve much, and I think mid-year, I think a decision, this in 2020, was made that I think now we needed to think about an alternative therapy to assist me manage this problem of my kidneys. And at this particular point, I think I had to do a surgery for a fistula that would help me to do dialysis. And by late July in 2020, I think I started my life on dialysis machines, and I think I've continued to date, currently attending dialysis twice a week just to support me. So I think that's paint a background of what I go through. A lot of that, I think the dialysis is just one of the many things that a renal patient goes through. But the other thing, there are also the medications that you use along that. As most of us might be aware here, that for renal patients, you are basically anemic, because a lot of this movement back and forth of your blood, I think there's so much that you lose. There's also the restriction on your diet and so many things. So there's also a lot of imbalance in your blood. And so you also do a lot of blood boosters in the process just to support you, either using erythropoietin or the iron injections. So these are some of the things that also come about when you're having a problem with your kidneys. So that's the background about this. Beyond dialysis as a renal therapy, I think there's also the reality of now a transplant, which is a more lasting solution to this. For me, I've been lucky to have tried both. At least in 2020, I think towards 2021, I had a brother who came up as a potential donor. We went through what was required as the test, I think at MTRH in Eldoret, but he didn't go through finally. I think in the latter stages of this, I think he was declared unfit to proceed. And he had to drop off, and we had to go back to my routine dialysis treatment. So one of the many things that we really look in this particular space is, yes, there are therapies available in the country for renal patients. Somebody can choose dialysis, which I think currently supported by the National Health Insurance Scheme. And routinely, I think we are covered for 2 sessions in a week. And there's also infrastructure in the country, both public and private, that can also support somebody to do a transplant. So I think public, I think we have KNH and MTRH who are able to support this. And those are available options that somebody can think of for a renal patient. But that is the one end of this particular story. I think the life of a renal patient is something that I would really touch on just before I proceed with the issue about kidney donations. And from my story, and I think what I also share from the other renal patients I interact with, is that the life of a renal patient is a daunting one. I think there's a real change of lifestyle, and you really have to confront a lot of things that routinely you are not aware about. And in the simplest way, I would say you enter in uncharted territory. And I think this brings a lot of things in your life that sometimes you never think about. One thing that I would really speak of is where as basic thing as just your change in physicality, the way you look, either you lose weight, you lose your form. That is the beginning of all this particular thing. The other things is just the restriction about that would also impact on your health and things like that. The other challenges that I think routinely patients will go through are things about the anxiety that comes with the fear that comes with it. The other problems could be things relating to finances, the emotional imbalances that comes to this. There's also the reality of chronic illnesses like any other. I think now that the issue about are you dying the following day. So those are some of the things that at least every other patient is confronting on a daily basis. And I think these are not easy things to do. The other critical thing that I think also come about this is now someone with a chronic illness is somebody who now need a support system around them. And it depends on how your situation is and how your health condition is. You might need serious support to really do a lot of things. There are people who just come to clinic on wheelchairs that need somebody to bring them on board. There are people who are routinely on caregiver support just to ensure that at least they're able to manage their lives. So these are some of the things that at least patients are able to confront. And in this, you also realize that you're also able to lose control about your life so much. When now 50% of what you do is controlled and supported by someone, you now lose a lot of control in your entire life. And sometimes this may not be easy with so many people. The reality of what finances also comes in that most of the patients, maybe you lose your productivity, you might, at the place of work, you might be relieved of your work, or maybe you make a decision that you cannot continue working. And these are some of the things that you really can. Then this now impact your finances. Finances, when that is impacted, then now the reality of now managing your medication, getting your transport to the hospital, and I've had situations where patients just miss their clinic because they can't fund their transport. Like for where I do my dialysis in Kisumu, I think there are patients who come as far as Vihiga, Kakamega, Homa Bay, just to have dialysis. And routinely somebody will miss dialysis because they couldn't fund transport to come to the hospital. So these are some of the realities about this. So in as much as, yes, the NHIF has made the regime a bit better for us, that at least you're able to bill, they're able to bill us to pay for the 2 sessions we are attending. But that is just one side of this particular story. There are also these other challenges that come about. So then that now takes us to the next discussion of speaking about what are the other treatment options that are available for this. Then now the question about transplant becomes topical now. Transplant now becomes with the donation of organ. And I think the regime in the country, yes, the transplants have been happening in Kenya for quite some time. A number of them happens in our public facilities, like Kenyatta has done a number. MTRH has also come in late, but also doing a number of them. The trouble with the public facility is that then there's also like it doesn't happen fast because there are several people in line for that transplant. So you could be scheduled maybe after a year or after several months, at least when you've already gotten a potential donor and have done the due diligence to the process required. The process is a bit easier in private facilities, which at least do not have a serious traffic on those who really need this service. The problem is cost. The costs are a bit higher in private facilities because then you have to pay for everything. So conservative estimates put the entire cost of transplant to be anywhere around 3 million. It could be as low as maybe $1 million or below that if maybe you have covers NHIF, which will help you maybe covering a section of this, which is made easier when maybe both the recipient and the donor are also covered and active cards. So that is the story about that particular one. But now the other reality is for you to have a donation, to have a kidney transplant or any other organ transplant, you need that organ to be available. Then that brings us to the next question: where are these particular organs? We know very well, yes, the outcomes when you have a transplant are better. I'll be able to move easily. I will no longer need dialysis and things like that. But the question is, where are these kidneys? Are there some places, is there a market there we're able to get these kidneys? There is no sale of organs and it's illegal in the country. And you also part of you're also signatory to other international laws that are also made this illegal. The question is, how easy is it someone to get a kidney? Be it from a friend, a relative, and such. So from the journey I went through, I think it's something not easy. I think I tried so much to really speak about it, but it's so difficult just to sit down and convince somebody to give you a kidney. And I think one of these things that I also realized, it's not as easy as maybe somebody really think about it. At some point, the people who are coming to donate kidney or people like my parents that were out of sympathy. But you look at the age difference, I think these are not the best options that you really get and require for those particular moments. So those are some of the challenges that really come about. But what the other thing is, you look at the same space, then as a patient, I have an advantage that I might be knowing so much, having interact with my doctors on this particular thing. The other thing would be, I'm also talking a point of disadvantage that at least the one who is suffering, and so I might convince you, but I might be hiding certain facts to you so that at least I'm able to get advantage over you. Those are some of the realities that we also know in this particular. So at what point will this be possible? So the common thing will be maybe you're a nephrologist, so your doctor will tell you, can you get somebody who's willing? You come, you bring them to me, I talk to them, at least so that at least I'm able to tell them what are the implications in this on their lives and things like that. So those are some of the things that have come about this. But the question still remains, are there all these people that can really able to come out and really donate kidneys for those who really need them? So that is the biggest problem here. So I think the discussion that is bringing us today in this meeting of, can the process be made better by maybe doing something like maybe creating an incentive to this particular process? So I think this is something we really need to look at. I think as much as, yes, it's a discussion that some people might feel difficulty in confronting, I think there's a reality that is something that we really need to think about and really start discussing along. There's a lot of things going around, I think prompted from the Health Act of 2016, that at least now allows for an opportunity for organ donation through written wills. But how much are we ready as a country to really take up this? I know the Western world is most of the donations of organs and the cells and tissues happened from now the dead donor programs. As a nation, are we really ready to go to that particular direction? But now the journey to that might take longer. But now we are discussing what is possible today. Being in a regime where at least we are using the live related donor, somebody close related to you in some way, maybe a blood relative or such. How do we make the process easier so that whoever is also giving the kidney at least is in a space where they are not so feeling that at least they've lost so much in this particular process of giving a kidney? Because there's also a reality that at least there could also be some health imbalances that can come about in this particular process. So as a renal patient, I think is a discussion that I would be ready to participate in. And I think as much as possible, I would wish more actors in this particular space, both the patients, their caregivers, the medics in this particular space, to really get an opportunity to really interrogate these particular subjects. How do we make this better? Can the incentives really make this better for somebody to really donate a kidney? And what is this form of incentive that we can really talk about in this particular discussion? Is it monetary? Is it a health insurance scheme? Or what sort of this consideration are we able to really give to this? We are alive to the fact that, yes, it's not about sale, but how do we really strike a balance so that at least we don't go to the edges where it is interpreted as if we sale of organ from one person to another. So I think this is something that I think as a patient, I'm excited that a discussion like this is ongoing. And I think it's something that we need more people to really speak to this. And we need to explore all the particular elements involved, be it the cultural issues, that could be the ethical issues, the legal issues, the challenges, the health issues that are all attendant to this particular discussion.
The idea here for us is that there's a general recognition in Africa and other parts of the world that the disease profile is not just changing, but a new challenge is rising. For a long time, most of the diseases have been infections, and then we've now started a transition, I think, which the WHO itself and the government of Kenya has since recognized, on non-communicable disease burden rising as well. So on the one hand, we have the disease burden related to communicable diseases, and then we have the non-communicable diseases. It may be driven by a whole it may be driven by many things. Some of them might be demographic changes, there might be lifestyle changes and all that. But the truth of the fact is that the structure of Kenya's health management and public health system will have to accommodate, or at least be alive to this changing disease profile and the burden of disease that Kenyans face. We've heard from Ken, and he's given us quite a succinct explanation as somebody who's actually, was healthy, and then had this health challenge, went through a series of diagnoses before it was finally nailed, and now he's living with a condition in which every two days in every week he has to go through dialysis, renal dialysis. And he's explained some of its costs. He's explained the social costs as opposed to just the financial costs. He's explained the existing infrastructure that's available, the preference or the availability of public health and private health provisions, and obviously the mix with insurance. So it's a very, given as a coherent story of a very complicated process. I'll call it a spaghetti bowl. It's also important for us, that's the demand side for treatment. It's important for us to look at professionals who actually handle, and they are caregivers, they conduct research in this area now. And we have with us Dr. Philip Cheptinga, who's a consultant nephrologist from the Moi Teaching and Referral Hospital. And he'll be speaking to us about the prevalence and trends in kidney disease and what he thinks are Kenya's policies affecting access to treatment. Thank you.
Thank you, Kwame. Thank you. Good morning, members. And sorry for the delay. I had ICT challenges, but now I'm on. This is quite interesting topic, and I just wanted to look at the prevalence and the trends in the kidney disease and the Kenya's policy affecting the access to treatment of the kidney disease. And let me start to say that infectious diseases led by HIV/AIDS, tuberculosis, and malaria are still leading the cause of death in sub-Saharan Africa. However, the contribution of the non-communicable diseases to the morbidity and mortality in the region has grown over the last 30 years. These emerging non-communicable diseases in Africa have been attributed at least in part of the improving the longevity, as well as urbanization and modernization of the cultures in the region. Cardiometabolic diseases have been suggested to be the leading contributor to the deaths due to the non-communicable diseases in sub-Saharan Africa. The high and rapidly increasing incidence of these cardiometabolic diseases reported across the diverse setting in the region. International Diabetes Federation projects Africa are set to witness the highest relative increase in the diabetes by 156% between 2017 and 2045, with the total population of adults with diabetes increasing from 16 million to over 41 million over this period. And the population in sub-Saharan Africa have also been shown to have the high prevalence of hypertension of 48% and obesity rate of 20%. And this is expected to increase over the same period. To this, we can also add the chronic kidney disease as shown by the Jaya, George, and colleagues in the Lancet Global Health. And in a cross-sectional population study that was involved 8,000 participants, aged 40 to 60 years at six centers in Africa. The overall prevalence of the chronic kidney disease was reported to be 10.7%, while the study of George and colleagues supports the results of 2018 meta-analysis that examined over 98,000 individuals from 98 studies in Africa, and reported overall prevalence of chronic kidney disease stage 1 to 5 to be 15.8, which has been very high compared to the 1980s and 1990s. Given the increasing incidence of hypertension, HIV, and diabetes in Africa, all which are independently associated with chronic kidney disease in the study by George and colleagues, the stage is set for a major disruption in the health provision that could demand major infrastructural changes and hefty increase in the health budgets if the efforts are not immediately met to prevent the onset of chronic kidney disease, as earlier on presenter said. And these significant differences, preference in chronic kidney disease between 4 sub-regions analysis, clear indication of the different transition stages across participating countries, and the preventive measures that have been put in place for HIV, although not optimal, might be of use to all the avoidant advanced prevalence of non-communicable diseases in Africa. And in this regard, similar to campaigns in East and Southern Africa aiming for individuals to find out their HIV status, individuals should be encouraged to find out their diabetes and hypertension status, which are strong determinants of chronic kidney disease in our region. Renal registries might also be useful in establishing the causes of the chronic kidney disease and the end-stage disease. I must report, member, that the Kenya Renal Association, the last 3 years or so, we started the chronic kidney disease registry. We have also started the kidney transplant registry and also acute kidney injury registry, and this was the same. The establishment of the African Renal Registry in 2015 by the African Association of Nephrology and the African Pediatric Nephrology Association could provide further data that might assist various health organizations in Africa to plan effective strategies. It's estimated GFR also is considered that the best overall index of the kidney function, and standardization of creatinine measurement, a key component in calculating the GFR, is crucial in identifying and stratifying patients accurately. Africa in general have huge challenges, particularly in Kenya, with shortage of qualified personnel and quality laboratory tests. I must tell you, members, that a lab test done in Nairobi, particular hospital, will not be the same results in a different hospital within Nairobi. And that brings the challenges of the quantity and the quality of these tests. And the figures published by the African Society of Laboratory Medicine, few laboratories outside South Africa have been aggregated to international recognized standards. And that explains why most of our samples are taken out to South Africa and India for the same very reason. And I think it's a high time the government look at this issue of quality in our labs so that we have the best results for our patients. With improvement in point of care testing technology and improved connectivity, such as testing for creatinine, can easily be introduced as part of the concerted effort to meet the quadruple pattern of HIV, diabetes, HIV, tuberculosis, and chronic kidney disease. And of greater importance is that 4 variable modification of the diet and chronic kidney disease epidemiological liberation equation can be used to estimate the GFR. And this is also important. When it comes to the risk factors of the kidney disease, data in the recent decades have linked to a host of genetic, environmental, socio-demographic, and clinical factors for the risk of the kidney disease. The population pattern of the kidney disease is also known to correlate to the socially defined factors in most societies across the world. And this phenomenon is better documented in high-income countries where the racial, ethnic minority groups and people of low social status carry a high pattern of the disease. And extensive data have demonstrated that racial and ethnic minorities, especially the African Americans in USA, Aborigines in Canada and Australia, and also other minorities in UK and other countries, are affected, exploded by the advanced and progressive kidney disease due to their status. And the association of the socioeconomic status and the risk of progression of kidney disease and eventually the kidney failure has also been described with persons of lower socioeconomic status, particularly in our region, Kenya included, whereby the recent works have also associated Apollo protein L1 risk variant to be associated with the kidney disease, especially the Black African people who live in Central America, Southern America, Mexico, and the rest of the world have high increased level of the kidney disease because of this particular gene. And multiple studies have also have the potential role in kidney disease of unknown causes. Regarding hydration, heat stress are common, especially in dry areas in our country, like the northern part of the country. Other perhaps more rapidly risky factors of the kidney disease progression, socially disadvantaged groups have been identified, including the disparate risk and poor control of the clinical risk factors, such as diabetes, hypertension, as well as the lifestyle behaviors. And this largely because there's no much has been put towards prevention of the disease through educating and also empowering our local communities to take care of the health, the way we have done with HIV, and this is what we should be doing. The diabetes is the leading cause of advanced kidney disease worldwide, and in 2016, 1 in every 11 adults worldwide had diabetes, and more than 80% were living in low-income and middle-income countries, where resources for optimal care are limited. After hypertension is also estimated to affect over 1 billion persons worldwide, and is the second leading contributor cause of chronic kidney disease. Hypertension control important for slowing chronic kidney disease progression and decreasing mortality risk among persons with or without chronic kidney disease. And I must say, members, that most of the patients who have chronic kidney disease, their major cause, one of the complications of that is the increased blood pressure. Unfortunately, mostly healthcare providers also don't know that, and also the patient don't know, because if you have high blood pressure, you should be able to think that most likely you have a kidney disease, and you should find out why are you having a kidney disease, chronic kidney disease. Lifestyle behaviors, including the dietary pattern, as well as they're strongly been associated with the social economic status, whereby the junk food is the main indicator here. High caloric intake, as well as the kind there's no work to be done, no exercise, and so forth. And the recent years, several healthful dietary patterns have been associated with favorable chronic kidney disease outcomes. While people living in low-income persons often face barriers to have health eating foods, actually end up increasing kidney diseases. People of low socioeconomic status experience food insecurity, that is limited access to affordable nutritious food, which is a risky factor for chronic kidney disease and progression of the chronic kidney failure. Members, allow me to look at the acute kidney injury, which is one of the progression. Almost 30% of patients with chronic kidney disease tend to progress to chronic kidney disease. And this has been associated with most of the cases is undetectable, and is estimated to have between 8 to 16% prevalence in the hospital admission, and is well established a major risk of the chronic kidney disease. The disparities in acute kidney injury risk are also common, following the pattern to similar to that observed in persons with chronic kidney disease. I must say acute kidney injury is related to the nephrotoxins. Alternative medicine, especially the traditional herbal medicines, infections, and hospital and related procedures are common in our setup. Other factors like snake bites, those who come from the where snakes like Baringo, malaria, pneumonia, and so forth. There are still, we see a number of them, of these patients having this. With this, then to have more cases, approximately 13 million cases per year are experienced in low-income countries. And in our Kenya, though we have not documented, we tend to see higher figure than what was reported here. I think in Eldoret, we have approximately 22% of the patients who are admitted at Moi Teaching and Referral Hospital. So let us look at the health policies and financing of the chronic kidney disease in Kenya. I'll start with Africa and then narrow to Kenya. And because of the complexity and the costly nature of the chronic kidney disease, it is provision is startling linked to the public policies and financial status of individual countries. For example, across domestic product is correlated with the lower dialysis to transplantation ratio, suggesting greater rates of kidney transplantation in more financially solvent nations. And in several high-income countries, universal health care is provided by the government, and it includes chronic kidney disease and any renal disease care, particularly the slowing blood progression, the dialysis, and transplantation. In other countries, such as the USA, care is publicly financed for citizens. However, optimal treatment for CKD and its risk factors may not be accessible for persons lacking healthcare insurance, and regular care of the undocumented immigrants with chronic kidney disease are not covered. In low-income countries, Kenya included, neither CKD or end-stage care can be publicly financed, and chronic kidney disease prevention efforts have been limited. I think the NHIF in the last 5 years have been helping the dialysis, but not optimal. And to make things worse, in the recent past, they have withdrawn even the purchase of the catheters, and also limiting the dialysis session. Instead of 3, they came to 2. And most of the time, the patients end up not having a quality life. In several such countries, collaboration between the public and the private sectors have emerged to provide funding. And I want to give you an example of in Karachi, Pakistan, a program for dialysis and kidney transplantation through joint community and the government funding has existed for the last 25 years. And in have no or limited public or public sector funding. A systematic review of 260 studies, including patients from 30 countries, actually shows reliance on the emergency care and fear of the catastrophic life events because of the diminished financial capacity to withstand them. Members, before 2015 in Kenya, families could sell whatever they have, including the plots, and within a month, all the resources were drained, and eventually the person dies, all the resources have gone, things were really bad, and we are not yet out of the woods yet. We still need more engagement with the government, the public, so that they understand and also they get the most support. Challenges may even be greater for families of children with end-stage renal disease because of many regions lack qualified pediatric care centers, particularly in Kenya. As you are aware, there is no dialysis for children. That's quite unfortunate, except the one Kenyatta does peritoneal dialysis, which is a bit slow because consumables are not available in the region. MTRH, we do the hemodialysis, but now the end stage is if you bring a child from Mombasa to Eldoret, from Migori to Eldoret, so from Turkana to Eldoret, how will they continue with the 2 to 3 sessions per week of dialysis? It's really difficult. At the moment, we have more than 126 children at MTRH. Most of them come from all over the country. They are stuck here. They call our home. As you are aware, I have one young man from TRT in Baringo East. They have been here for the last 7 years. He reported to the hospital in 2017, and the parents have since left him in 2017. They have never come back. He came at the age of just in such cases. Nobody to donate, nobody is taking care of him. The hospital is the mother and the father. He's also the school and so forth. Those are the challenges we face. Let us look at the organizational structures of the kidney disease. The lack of recognition and therefore the absence of global attention plan for kidney disease partly explains the substantial variation in the structure and the capacity of the kidney care around the globe. And this situation has resulted in variation in the government priorities, healthcare related budgets, care structures, and human resource availability. Effective and sustainable advocacy efforts are needed at global and national level to get kidney disease recognized and placed on the global agenda. I want to appreciate our partners. I want to appreciate our patients and more so Kenyans. I think we are on the national map almost on a daily basis. We have really done our best, and we still need more and more energy. I want to also recognize the media for support they have given us for the same. In 2017, the ISN collected data on the country level capacity of kidney care delivery using the survey. and the Global Kidney Health Atlas, which is aligned with WHO building blocks of the health systems. It highlights limited awareness of the kidney disease and its consequences and the persistent inequalities in resources required to tackle the pattern of the kidney disease across the globe. And for example, chronic kidney disease was recognized as a healthcare priority by government in only 36% of the countries that participate in this survey. Kenya was among the countries which was surveyed, and it's recognized. And the priority was inversely related to income level. And CKD was a healthcare priority in more than half of those low income and low in middle income countries, but less than 30% of the urban middle income and high income countries. And this brought the issues why the international community is not bringing the issue up. Look at renal replacement therapy, as alluded earlier on by the first presenter. The distribution of renal replacement therapy, that is renal dialysis as well as transplant, is varied widely. And on the surface, all countries report having long-term dialysis services, and more than 90% of the country reporting having short-term hemodialysis. However, access and distribution of renal replacement therapy across the countries and regions were highly inequitable, often requiring prohibitive out-of-the-pocket expenditure, particularly in low-income countries. If you take an example in Kenya, though the dialysis is provided by NHIF, there are still costs on transport. Most patients, they need a HELIPA, they need transport, they need food, they need lunch, and this really, they're also quite expensive for them, and they have to do this 2 to 3 times a week. More than 90% of the urban middle income and high income countries reported having chronic peritoneal dialysis services, whereas these services are available in 64 and 35% of low income countries, respectively. This service is not available in Kenya, peritoneal dialysis, for the same reasons. Next one, if you look at the workforce, nephrologists per million population was very common in low-income countries, whereas its highest is 15 nephrologists per million population, was reported mainly in high-income countries. At the moment, Kenya, we have slightly over 40 nephrologists to cover over 60 nephrologists, so we are still below the 1 million. We actually at 0.5 nephrologists per million population. But I want to bring your attention that we do have only 5 pediatric nephrologists in the country to cover over 40 million children in our country. That brings even to be even lower. And really, that brings the reason why there's a problem in terms of the integration of this particular population. Most countries report nephrologists are primarily responsible for both chronic and acute kidney care, and the primary care physician had more responsibility for chronic kidney disease care than acute kidney injury, as well as 64 countries reported that primary care physicians are primarily responsible for chronic kidney disease, and that 5% reported that they are responsible for acute kidney injury. Intensive care services specialists are primarily responsible for acute kidney injury in 75% of the country, and the likely cause is typically related treated in the hospital. Remember, Kenya, we have less than 5 intensivist specialists in our country. And this has been attributed to the fact that the country has never recognized this subspecialization, and they have never understood their roles. And that brings why the mortality in our country is quite high. Sometimes we could actually save a number of lives here. Allow me, members, to go to the, because of time, to the conclusion that socially disadvantaged persons experience a disproportionate pattern of the kidney disease worldwide, and the provision and delivery of the kidney disease care varies widely across the world, and achieving universal health coverage worldwide by 2030 is still one of the WHO Sustainable Development Goals. Although universal health coverage may not include all elements of the kidney care in all countries, because of this is usually a function of the political, economic, and cultural factors, as my earlier on presenter put it. Understanding what is feasible and important for a country or region with focus on the reducing the pattern and the consequences of kidney disease would be an important step towards achieving kidney health equality in the world. And more so, I want to also appreciate that those who will be having the kidney disease, possibly the donors, will be actually be in proportional. So there will be more patients, less donors, and of course they will also create fear. And this is why there's need for us to have and look at the deceased organ donation in our country, and more so, how do we appreciate and compensate them? It's also a healthy decision, and I think it's important for you and I to look at should the donors be compensated by the government for their support in relieving and supporting these patients, or these are loophole patients, people are going to take advantage and take advantage of the poor in the society. Thank you, members, and welcome for the discussion.
Thank you very much, Dr. Philip Sheptinga. Thanks a lot for the very comprehensive narration regarding what the state of affairs is. So you started by telling us what the prevalence is. You mentioned specifically that predictors of kidney disease are usually hypertension, diabetes, all of which are expected to rise not just in Kenya, but most of the African continent, suggesting to us that obviously we need to bring this question, give this question a higher priority. Of course, there are also other health concerns, but we need to be careful. One of the areas that you mentioned that I think is even more essential is that the disease burden is definitely regarding CKD is going to rise, but at the same time, the number of nephrologists are very few. The other thing is that not only are they few, but the pediatric nephrologists, I think that's what you call it, are even fewer. You say that there are only 4 of them in, no, there are 40 nephrologists for the whole country, which puts Kenya's as less than 1 per million. But also the nephrologists who deal specifically with children is even smaller, suggesting that burden is here. So Kenyans, as part of our health policy and financing of health workers, is something that it tells us that there's going to be quite some other things to do. Then you mentioned a case, I think, which is also very important. The human side of this is that families and treatment is such a big economic burden that sometimes families even abandon children. So you have this child, you say, that's been there since 2017 in a hospital being taken care of by anti-reg. And I think that's quite an interesting. I mean, that's something to bear in mind. You also stated something about priority of CKD globally related to is inversely related to the income levels. And even Kenya as a lower middle income country, I think is still much lower than others. So obviously there's work to be done here. And one other thing that you said is, yes, I think you distinguished for us between the treatments in the maintenance of a chronic illness. And I think as the first person, the first panelist also mentioned that replacement therapies are there. There are challenges as well, but it's clear both of you seem to be suggesting that there's still some scope for expanding the possibility of renal replacement. And then you mentioned that there's no dialysis for children, which I found very, very interesting as well. But I think you also say that some of the causes which drive illness, acute kidney injury in Kenya, which is some of these herbal supplements that Kenyans need to, like quite a bit. All these herbal and traditional medicines that some Kenyans consume, and they get recommended to us as healthy because they are from natural products, but as you're suggesting, they're actually quite injurious. So obviously there's a public education role. We will have an opportunity for a question and answer for all of our panelists. But in the meantime, we have colleagues from the Institute of Economic Affairs who each will have about 7 minutes. So one will talk about the demand side, responding to what the economics of Ken's presentation, and then the other will speak about the supply dynamics. So Maureen, please go ahead.
Of kidney failure and transplants. We'll also be informing policy about the markets on transplant and transfusion, because during the dialysis process, blood transfusion is also involved, and also looking at whether the available resources are used in the most cost-effective way. Next slide, please. Okay, so we look at data on kidney disease prevalence in Kenya. Looking at data from the Kenya Renal Association, they state that at least 4 million Kenyans are suffering from renal disease, and for this 4 million Kenyans who are suffering from the renal disease, there's at least 0.7 nephrologists per million population, which is below the required threshold, which is like 1 per million population in low-income countries, which Kenya is one. Also, the number of dialysis patients per million population is 5,670, and the total dialysis units is 214, out of which 54 public units, then 143 private units, and 17 are faith-based. From this, we can see that a large share of dialysis units are from the are provided by private bodies. From the 2 previous panelists who've explained, we can get that dialysis in private centers paid by NHIF, as well as paid from the pocket, is pretty expensive. We can also see that the cost of dialysis per session funded by NHIF is $95, and then the patient has to top up the rest. And also the frequency of dialysis. Dialysis is done for 4 hours, and it's done twice weekly. And when it's done twice weekly, then NHIF funds $95. That's like around $190 weekly, funded by NHIF, and this dialysis is done like 8 times in a month. So you can imagine what the government is incurring, as well as the individual, when going for this dialysis. Also, kidney transplantation funded by NHIF. NHIF funds a maximum of $5,000. Then the patient has to pay the rest from out of pocket. Also, Kenya's death rate from kidney disease, we have 23.30 per 100,000 population. At least 23.30 people die from kidney disease annually per 1,000 population, per 100,000 population. And also deaths resulting from kidney disease are like 4,464 per annum out of the total causes of death, and this is like 1.69%. So what do we get from here? From the deaths that occur, that's 4,464 per annum, which is like 12.23 per day. At least 12 people die from kidney disease, and that's like 0.5 per hour. So we can say that from this, the prevalence from chronic kidney disease is used, and it's something that we need to have a conversation about. Next slide, please. Also, data from the World Life Expectancy website in collaboration with the WHO identifies kidney disease as the 15th distinct cause of death out of 27 in Kenya. They've listed several causes of death in Kenya, from traffic accidents, HIV, and they've identified kidney disease as the 15th distinct cause of death out of the 27 in Kenya. And Kenya was ranked as the 91st worldwide in terms of the share of its population that dies of kidney disease in 2022. The 91st position might not look as bad, but from the previous presenter, they've mentioned that it's getting worse, because looking at the causes, type 2 diabetes and hypertension, like in future, there's a projection of more patients will be under dialysis. Next slide, please. So next we move to the demand side problems. From the two previous presenters and also the numbers that we've shown before, there seems to be demand for renal replacement therapy because it's cost effective, as well as it's the most effective in improving in elongating the life of a patient, as well as the quality of their life. So under demand for renal replacement therapy, we look at costs. From an analysis by Randolph, David, and Rigma in 2013, the total cost of treatment from a milder chronic kidney disease is much higher than the cost of treating kidney failure or by replacement therapy. This means the cost of frequent dialysis twice per week, which is done in Kenya, which is even less than the global threshold, which is to be done thrice weekly. And the dialysis that it's done over the whole lifetime of a person. It's the cost is much higher compared to doing a transplant. For doing transplant once, it might be costly, but it's much cheaper when you compare the cost of transplant and dialysis over a lifetime. Also, under the demand for renal replacement therapy, we're looking at the availability of organs. Yes, there's demand for organs, but there seems to be a supply issue when it comes to the availability of organs. And also, we look at the safety on both sides. Is it before donation is done, they have to conduct a number of tests, like the patient has mentioned. He had a relative who had a couple of tests and they will not be able to donate. So when these tests are done, is it safe for the recipient, as well as is it safe for the donor to give the kidney? Next, we move to the issue of altruism. Altruism will define it as it's defined as an organ should be a selfless gift from a donor who should not expect any reward in terms of monetary or whatever reward. It's just supposed to be a donation. And governments have been encouraging kidney donation, but they forbid monetary payments to donors or the heirs of the kidney donation. The shortage of kidney for transplantation is due to lack of legislation supported by local community, lack of ethical and moral approval, scarcity of professional skills, and lack of quality of equipment and institutions. Globally and even in Kenya, there's a legislation against monetizing, like monetary compensation for kidney donation. But there are some instances where compensation for kidney donation is legal. For instance, a country like Iran, where the government manages the whole kidney market, whereby if someone needs a kidney, they are matched with the donor by the government, and the government takes care of the donor through comprehensive healthcare coverage for, say, a year. Then their health insurance is subsidized for the rest of the years, and they're also given a monetary compensation of $4,500. And the government also has a policy of looking into who's funding the donation, among other things. And maybe compensation for kidney donation should be made available as an option for chronic kidney disease patients. Next, we move to coercion. Coercion has been a topic against the issue of compensation for kidney donation, whereby the government thinks poor people will be exploited by giving out their kidneys. But is this really an issue, since maybe the person who needs the kidney might not be in a position to pay, or maybe they don't have like health insurance to support them. Maybe by providing alternatives, everyone will be supported. The last issue is the issue of income. Income is a demand-side problem. Looking at the cost that someone incurs in maybe dialysis, the tests, maybe the donor before the test, before donating, and even the transplant cost. Income becomes a big issue in this instance, where someone needs constant income to do this. And looking at the GDP per capita, it might not be enough to sustain this whole process. And okay, looking at all these factors, there seems to be a market failure. There seems to be demand for kidneys by the kidney patients, but there's a supply issue, and market failure is described as sort of a disorganization between the demand and supply. So the government needs to do something regarding the market failure in the kidney market. Yeah, thank you.
Thank you, Maureen. So my colleague just led you through the demand side dynamics of the market for kidneys and the market for kidney transplants. Sorry, the market for kidney transplant and the market for dialysis, kidney dialysis treatment, right? Now, I want to lead you through the supply dynamics. Now, what we've seen on the demand side can be all put together is to say that, look, Kenya is a relatively poor country. Kenyans are relatively poor on the one hand. So this is serving to constrain their demand for these products. But there are measures that can be taken on the supply side to actually begin to depress the price so that those patients who need these services and who will continue to need them for the foreseeable future, as our previous presenter showed, with the impending increase in demand for kidney treatments, then this means that something perhaps should be done. Now, we have the meager resources of a poor developing country. We've seen constraints in the supply of health insurance products. There's a constraint in the supply of kidney illness surveillance infrastructure and specialists, a shortage in the supply of dialysis treatment infrastructure and specialists, shortage in the supply of facilities and specialists to carry out kidney transplants, and a legal code that also serves to constrain the supply of kidneys, right? So all this together, it's saying that in the future, because already we're seeing signs that, look, dialysis services are being rationed, kidneys are not in supply. So even adding to the fact that the facilities and the specialists themselves are not enough, we also don't have enough of an availability for kidneys. Now, here we have a chart that shows some of the challenges to providing comprehensive kidney care in Kenya. This is from Global Dialysis Perspective. It's from a journal on kidney treatment, a global journal, right? Now, patient factors. What this row here that is called patient factors is trying to illustrate, to show, is that there are problems related to the problem of detecting the kidney problem as it relates to income. Now, imagine the average Kenyan earning $2,000 a year. He doesn't frequent the hospital for the annual checkups. You can see with our welcome guest, our presenter, the first presenter, that even he had issues with misdiagnosis for a very long period of time. Furthermore, some of the medications can be quite costly. They have to be paid for out of pocket. The diagnostic tests are not of the highest quality. You know, the doctor showed something that was very important for us to note, that you cannot just take the renal treatment infrastructure from, say, the United Kingdom and parachute it here in Kenya and expect it to work as it does there. Why? Because he presented that there's a very important information component that not only do we need to detect the disease within patients, but we also need to collect data on the disease, so that, because every country, a geographic region, and the demographic with a different demographic profile, it's specific information that the medical specialists need to collect over time in order to design their services to meet both present and future demand. The next slide, please. Next. Now, finally, to top it off, previous slide, please. In Kenya, one Nation Daily newspaper article actually said that the Kenya National Hospital can carry out about one kidney transplant every 3 days. But taking the data about the deaths from these diseases, we notice that in that time, about 36 people will have died while they transplant one disease. That's a sign of a system under considerable strain. We take another example now, moving from the market for kidney transplant to the market for dialysis treatment. If when a dialysis machine is down, actually the system endures considerable shock. You know, the lineups that are already there only grow. Now, this again is a sign of a system under considerable strain. Finally, consider the insurance products of the national Kenya's public health insurance body only pays for 2 out of 3 globally mandated sessions that are required for dialysis, right? So that means, again, the system is rationing the treatment. So this tells us that, speaking from an economic perspective, there is a market failure that needs to be addressed. Finally, when we talk about the legal framework assumes many things. One of the assumptions we can see is that altruism is supposed to be the resolution to the requirement for kidney treatment. Now, if you do the mathematics, take average Kenyan earning 2,000 and some change dollars a year, and assuming that if this patient paid $14, that is on top of the, say, $95 that the NHIF already gives, and he tried to meet his requirement of 3 sessions a week, he would actually wipe out his annual income. So that shows you that people face considerable financial strain. This was illustrated again with a very real example of our presenter. Now, the government assumes that if you are not related to someone who needs a kidney, because a kidney transplant actually would cost less than paying for dialysis for your whole life, it assumes that someone who's not related to you did not give you the kidney on an altruistic basis, and it tries to restrict this from happening. This means that the supply of kidneys actually is constrained. We'll contrast this with the experience of Iran. Now, Iran and I believe Iraq both have a legal framework that allows financial incentives for kidney transplants, right? For kidney donation. It was also illustrated that in addition to these incentives, you need something more, like maybe an insurance policy, because the patient, the donor will be worried about the cost of a failed surgery, right? Now, that is all for my supply side dynamics. But what we can see is that we really need to reconsider how we are spending our public health resources. Now, the reason why economists are here talking about what seems to be a medical problem is because this is a resource outlay required. So we're trying to assess the resource outlay and whether this resource outlay is efficient. What do we find? Market failure. The market is failing, and we need to do something to relieve the pressures. One of the measures we suggest is open up the trade, the exchange of kidneys, include some incentives. Thank you.
Right. Okay, thanks a lot. It's been a while. Thanks a lot. So we've had two main presentations, one from Ken and the other from Dr. Cheptinga. And then we had my colleagues each spend about 10 minutes, to spend a little bit more than that, talking about what they see as the demand side dynamics and the supply side dynamics. I'd like to remind you that, yes, we'll circulate the presentations. I think Dr. Cheptinga asked for the presentation and we sent to him. But we come to this part, it's a little later than we anticipated, but we come to this part where we now have to have a discussions and question and answers. So we have our two main panelists, Ken and Dr. Cheptinga Philip. And so please, for all of you who might have any questions, please send the questions either through the chat or just raise your hand using the menu bar right at the top, and I'll call upon you to ask any questions. In the meantime, as your questions come through, I'll ask either Ken first, and then Philip later, to just give us 3 minutes of what they think about anything that they'd like to add or anything about what my colleagues have stated. And for the rest of us participating here, please send your questions either through the chat or you can raise your hand using the menu bars. And I'll read out the questions or I'll allow you to ask those questions. So let me start with Ken. Ken, since you're here, if you could turn on your camera and please make some comments based on what my colleagues have mentioned or anything else you think you'd like us to hear. Go ahead.
Okay, thank you for the opportunity. I think the issues are related from both Doc and I think Maureen and Emmanuel. I think they're related. I think there's a general agreement that there are issues on both demand and supply side, and I think that's a good way to really pitch the discussion, so that because we are in agreement on a number of issues that are both emanating from both ends. So the only thing I would add is maybe a comparative costing of both transplant. Like for somebody who is on dialysis, like me, spending 76,000 a month, that is what is billed to NHIF. And the other medication that come along, that would maybe push the figure to over 100,000 in a month. So comparatively, if I was a transplant patient who will need the immunosuppressant, this could be something between 30 to 50,000 a month. So comparatively, you'd also see there's a value in a transplant, and I think the cost, essentially, if the government was really to give the immunosuppressants for renal, so the transplanted patient, then I think there's also about the cost effectiveness of that particular. So it's also a discussion that we also need to exploit it, that particular angle, and looking at the element of cost. So if the government can really come in to really support the transplant regime in the country, then I think there's also a possibility that we're also doing a cost-saving measure. So I think that is the other angle to really add to the entire discussion. But I think the other important issues in this discussion have been brought forward by the different speakers. Thank you.
All right, thanks a lot, Ken. What about Philip? Dr. Cheptinga, do you have any comments?
Thank you, members. Thank you, Kwame. I wanted to add on that the universal health coverage is key driver to achieving most of the challenges we face at the moment, especially in terms of financing. And as Justus put it, we need to look at the laws which are limiting us in terms of supporting the kidney transplant in our country, and also the liver. As we see, most of the time there are other organs which are required. For every one person dying, they will donate a minimum of 69 organs to 69 people. So really, if you look at the South African to say that let us engage the government to ensure that there is universal health coverage, also to request the county governments to really take it to ensure that its members, its population are members of NHIF, and ensure that there are legislation to provide the same. I think on the aspect of the Kenya Renal Association, we are ready, and the other healthcare providers, we are ready to spearhead the process. This has been an eye-opener, members. I'm very grateful myself, and indeed, I wish to share with you that there is a organ transplantation team, which organization with a CEO. I think we should also reach them. I would also wish to invite you to the Kenya Renal Association. Now you are here. In our future meetings, we are going to invite you for the same. Thank you.
All right, thanks a lot. Thanks a lot, Philip. I haven't seen any questions, and I have my own questions, hot questions, but let me keep them on the side. Okay, so there's a question here from Beatrice, right? Okay, there are two questions, so I'll read them out. So the first is by Stephen, and then we can circulate them among the panelists. So Stephen Jairo asks, he's our colleague at the Institute of Economic Affairs. He asks us that, can the model in Iran for compensation to donors be replicated in Kenya? For how long is it applicable to the donor? Some time or for a lifetime? I think that's what he meant. So because that was mentioned by Maureen and Emmanuel, I think they would answer that. Beatrice Mboga, I hope I read your name correctly, says, I am Beatrice, a renal patient at Kisumu Specialist Hospital. I'm asking whether the government can come up with a program where kidney patients are given upkeep, because for kidney patients and compensation like it is done in the US. So again, you're asking questions. So that would probably be a question for Dr. Cheptinga to answer. So let me start by reversing the responses. So let's start with Maureen and Emmanuel. Please answer Jairo's question, and then we can go to Dr. Cheptinga and Ken to answer Beatrice's question. So Emmanuel and Mo, please go ahead and make it quick.
Yes, thank you, Steve, for your question. Yes, so just to quickly reiterate, Iran faced a lot of pressure for kidney transplants and kidney treatment, right? So the religious leaders actually declared that it was religiously appropriate to pay people for kidneys. Now, then the government took it up, and now in Iran, it is the government itself that pays donors for their kidneys, right? And so what is the effect of this program? By 1999, the backlog for dialysis and for kidney transplants was actually reduced to zero. So they have no more backlogs. And in fact, in the present day, Iran is one of the major exporters of the dialysis machines. So it's so yes, in theory, the program can actually be implemented here. Take away the fear of say allowing people to the open markets to trade in kidney and say only the government can pay people. Yeah, and have the government pay people for the kidneys, so it can be. Yeah.
All right, Mo, do you have anything to add?
Yeah. Okay. For a long time, the argument against providing compensation to donor has been focusing on the claim that the implementing incentive programs will be troublesome, or rather, and also to protect prospective donors from exploitation. But Iran government has been running it on by itself, the management, the compensation, and everything. I think it's possible to implement it, like you've asked, and it will reduce the delay for the patients on the list waiting for donations. Yeah, thank you.
All right, so let me come now to Philip. Philip, your question is, what's your view? I mean, here's Beatrice asking whether, as a renal patient, we should ask government to consider upkeep.
Kwame, may I repeat? Hello?
Yes,
Kwame,
let me repeat the question.
Yes.
Let me repeat it. So Beatrice, a renal patient at Kisumu Specialist Hospital, is asking
Yes.
whether the government can come up with a program where kidney patients are given upkeep. And for kidney patients and compensation like it is done in the United States.
Thank you, Kwame. I must say yes, because these patients, before they got the kidney disease, they contributed to the Kenyan economy, and they deserve to be compensated. Secondly, they also, most of them, they tend to have a lot of challenges in terms of getting the basic necessities. And I think I support the proposal to be given the upkeep so that they can also continue getting quality food, quality medicine, and quality life. And allow me to respond to the issue of Iran government. Yes, it's possible. We have such a program in Kenya and can be done very well. Usually, the religious community, they just need to be educated. I think if you look at the Catholic faithful under the Pope, Pontiff, the Pope, yearly they meet and discuss on the issues of kidney transplant, on organ transplantation. Maybe I'll just send you one of the programs we had last year, 2021, in Rome. And indeed, it's one of the successful programs which really need to be echoed and followed. Having said that also, as a country, we need to build the human capacity, especially the health workers, in particular the kidney transplantation, the liver and other organs, maybe the heart. I think I want to give you an example of Sudan, whereby they do more than 1,000 transplants for children every year. And I think other than Iran, Sudan is coming second in terms of organ transplantation, and this largely because of their way they have trained their own staff, the health workers, and they move from one region to the next one. For example, they can say this month we are in Mombasa, next month we are in Nyeri, the following month you are in Rift Valley, and then Kisumu Western, and then before the end of the year we are in Mandera or Kariza, and they go around down the whole year like that. And this has led to a high number of patients receiving quality treatment. The government should actually provide the post-transplant medication free to all of them, because as said earlier on, to do a dialysis per month is 100,000 Kenya shillings, vis-a-vis the post-transplant medication, which is 20,000 or 30,000. So the government tend to save over 6 billion Kenya shillings per year by transplanting, by supporting this patient through transplant and post-transplant per year. Thank you.
All right. Thanks a lot. Ken, do you have anything to add?
I think I would speak on the issue about compensation that has been raised by Beatrice. I think it's something that is possible for government to really take up, because I look at there are a number of indigent programs that are running across the country, be it the one for the disability persons, the other one for the elderly. So I think there's a space that government can really explore and really look at the chronic diseases like now kidney disease, chronic kidney disease, and see to what extent they're able to support. I think it's something possible, maybe through a monthly stipend, something like that, because the vulnerability is too much, and it's painful sometimes to witness a situation where somebody is unable to get to the hospital just because they are missing, they're unable to afford their fare to the facility. So I think there is need to really do something about it. I think government is capable to really come in and really support in this way. And I think it's something that can be explored further. Thank you.
All right. So, I mean, it's about time that we agreed we'd be leaving, because we agreed we'd be leaving at 12:15, but I haven't seen any other questions. So because there are no other questions, I'll be asking our colleagues to do their final remarks. But before that, I'll ask two things that came from the presentation from both panelists, the main panelists. So one of the things that Dr. Chamtinga said was, Philip said, was that confirmations and the diagnosis of renal illness in Kenya tends to be done outside the country, and you mentioned specifically South Africa. That obviously has a cost component. And you mentioned a word that lab tests, sometimes even when they're all done in Nairobi, tend to differ. Please explain to us why. I found that a really, really curious thing. And the second one was something that I also think we need to consider here. You stated that the African race, or let me say the black people, basically skin like mine, most of whom reside on the African continent, have a genetic predisposition to, is it hypertension, which then obviously creates the probability that this is a driver of kidney disease. I hope I had that right. So if those two, let's answer those questions, and then I'll come back to everybody to give their final comments. So that's specifically to Philip. Philip, please respond to those two questions. And they're specifically the question about the differences in lab tests results. And the second one is the black people's predisposition to kidney disease via the predisposition to high blood pressure. Yeah, go ahead.
Thank you very much, Kwame. As you are all aware, most of our lab machines, equipments, procedures, calibration of the machines are not controlled. Let me give you an example. There's China made, poor China made. So that is what. So people go for the machine, but they don't go for the quality. And that explains why we have these challenges in our laboratory. If you come to like a city like Eldoret, or even wherever you are, if you test for malaria, I'm sure as one lab will say it's positive, another lab will say negative. And this is because, and the human resource training, the exposure, they're all standardized. If you look at a country like South Africa, they have laboratory services is like KRA, and it's nationalized. And most of the time, it's controlled. So a hospital does not have its own lab, but they would source the services to the National Laboratory Service, which is based largely in Johannesburg and Cape Town. And I think as a country moving forward, it's high time it's high time we regulate the same for the benefit of our patients. The issues of on the second question, why the second question was what on what, Kwame, kindly?
The second question came from your presentation. I forget the slide number.
I've remembered the issue of
Yes.
the hypertension.
Yes, and
Why
predisposition.
hypertension is high, and rather the chronic kidney disease is high among the Black population. Actually, it's because of a gene which is common among the Black population. This has also been attributed to the HIV. Why the HIV is high among the Black population, and I'll tell you most likely this is because of God's creation. There was a purpose for creation of such, because most of the time is protective to certain conditions, particularly the sickle cell disease, among others. But of course, in the event of the hypertension, it tends to worsen our situation in our countries, in the Black population. So that should explain that. Let me take example of the coronavirus. It was not severe among the African population, the Black people, but it was severe among the whites. We don't know why. Most likely there would be another gene which which the Black population has, or we don't have, while the whites have or they don't have. Thank you.
Okay, thanks a lot. Fine. So what I'll do now is I'll circle the table for. I haven't seen any other chat questions in the chat box. Oh, somebody is talking about. Beatrice has mentioned that. Beatrice Mboga, she says, and no one has spoken about introducing kidney organ banks in Kenya. Is the government planning any such project and tissue testing in Kenya? Because currently they have to send this test. Okay, that's been answered by the question on labs. But I think you mentioned something about the renal databases and renal all that. So that could be part of the conclusion. But I think Beatrice, that had been mentioned as part of the renal databases mentioned by Dr. Chiptenga, but it's also been mentioned by my colleagues. Now, because it's our time to
maybe Kwame, I just wanted to inform you that currently now, the IAKI, the East Africa Kidney Institute, they started developing the HLA typing, which we are under testing. At Moi Teaching and Referral Hospital, we have just started also the flow cytometry, which will be able to do donor-specific antibodies and the T-cell cross-match. So hopefully, by next few years, we shall be able to do most of these tests towards the same. Thank you.
Right. Thanks a lot. Okay, I'll come now to all our panelists to make their final comments, and I'll reverse the order. So I'll start with Emmanuel and then Maureen. So please make any final comments. Then I'll come to Ken and ask Dr. Cheptinga to complete it for us. Your final comments. Maureen and Emmanuel, please switch on your cameras and make your final comments.
Yes, thank you very much. I think my final comment would be that this particular market failure is yet another, we find ourselves with another problem that is a great opportunity cost in just having poorly conceived fiscal policies and then poorly conceived budgets in general, and that every time you waste money, there's all kinds of issues that you don't see day to day, but that are potentially, we suffer the costs. And so my final comment would be that we should consider what can be done to depress the price of kidney treatment, kidney transplants, and actually increase the supply of kidneys, have those conversations, exchange, and open up the sources of kidneys.
All right, thanks. So, Maureen? You're muted, Maureen. Please unmute your mic.
Okay, sorry. Clearly from the numbers that we've seen from both the demand and supply side, compensation for kidney donation is a conversation that we need to have. An altruistic motive, it's noble and loving, but at the same time, it should not be the only alternative that we have when it comes to helping the kidney patients. And so the government needs to consider compensation for kidney donation as something going forward. Yeah, thank you.
Thanks. Ken, your final comments?
I think for me is to say I think it's a good way to begin, and it's a good way to begin. And I think there's a lot going on in this particular space at the moment. I think both government is trying to. I think I'm alive to the fact that there are some amendments being done to the Health Act. Then there's also the authority that was put in place by the former president Kenyatta. That was to look into issues about transplantation and organ donation in the country. So I think there's an opportunity and a space to really see how we really escalate this particular discussion to those spaces, so that at least this particular discussion on how we make the regime better, because we've also seen the example that has been shared, the Sudan cases and the Iran. I think these are the case studies that we can really look into and see to what extent are we able to really pick good elements from them and see what works within our country. And I think Daktari has also pointed to a number of things that we also need to be careful about. Generally, the emerging health trends on non-communicable diseases that at least as a country, we also need to really put a lot of investment to really see that we do not really lose a lot at the end of the day in trying to really deal with cases that can be dealt with early enough before the symptoms before the cases becomes very severe. So thanks so much for the Institute and the other panelists for speaking on these particular issues and taking time to really speak to our issues as renal patients. We appreciate it.
Thank you. Philip, your concluding remarks, please.
Thank you, Kwame. I wanted to sincerely thank the Institute of Economic Affairs and also the panelists. I want to say it has been an eye-opener for all of us. And having said that, I think it's important for us we look in terms of the key factor which are going to drive us into achieving what we have discussed today. We need to develop the human capacity, both for the health workers, the administration, and also in terms of the finances, because together we stand, divided we fall. And I think this is what has been the missing link for some time. We have not had a very important link for all of us as a country as we look forward into the universal health coverage and roll to every individual Kenyan, so that everybody can afford access health at affordable cost, not out of pocket. And that's why I look forward more, maybe in future we have more and more engagement towards the same And I hope the Institute of Economic Affairs will steer and guide us into achieving all these goals, the way Iran has achieved and Sudan. Thank you.
All right. Okay, thanks a lot. So for the IEA, the purpose of this conversation was to hear from the demand side, and we've had a very compelling case from Ken about how his treatment course has gone, starting from obviously diagnosis all the way up. And it's told us what the existing challenges are on the public health system, but also the costs that a patient bears, which are not just the costs of direct costs of treatment and dialysis, but actually the other social costs and the burden that it inflicts upon a family, the support system that is required, the ability to actually be economically active on the one side. And then we have Dr. Cheptinga, who takes care of patients as a caregiver and talks about this. And the first thing that becomes obvious to me as you put the two stories together is that the public health system is actually a system. So it's basically not pockets here and there. And all these are interlocking links between one another, what patients are capable of. And he said three things. One, the health workers base to be able to deal with non-communicable diseases generally, kidney illness more specifically, is actually very small. And if I look at the population growth rates and the growth rates for health management, nephrologists, it's very, very clear that population growth rates are actually much higher, suggesting that the development of human resources for these particular conditions in general becomes a huge demand, but also a priority for us. So that's the first one. The second point is that the economics of treatment, which obviously impose burdens on the system, but also on patients, suggest to us that renal replacement therapies are superior, which is basically donations. But this is itself constrained by the absence of a donor registry. And obviously the number of donations every year is much, much less. We saw data which suggests that there are 4,000, at least 40,000, 10,000 patients every year. And the replacement in terms of the kidney transplants, which is the most efficient treatment cost, is actually less than 1% per year. So obviously that capacity domestically needs to be expanded, but also it suggests that managing patients in such a way that is more cost effective means more donations need to come on. The existing infrastructure and law does not allow for those donations to come in as quickly, because Ken told us what the very rigorous assessment is, suggesting that the possibility of compensation should be considered. And I think it's something that people should speak about a little bit, open up that conversation on how compensation should be done. Finding resources to make compensation possible to allow for more healthy people to actually make donations and support lives is essential. The third thing that's become clear to us is for healthy human beings, myself and others included, without the diagnosis of an illness, we actually have one extra kidney. And I think this makes it a little different from other organ donations in the sense that it is possible for a person to live a healthy life if they have one kidney that is fully alive and functioning. And therefore, it means that the resource base that could be used to solve this renal kidney disease actually does exist. And the systems that are required to bring it all together is one of the reasons why we say this is a failing market, or rather an absent market, and that can be created. And my colleagues told us about the demand and supply dynamics, suggesting that other countries have actually gone ahead through progressive health policy to advance systems that allow for some kind of market, this market to actually operate more efficiently. So the IEA takes this knowing that obviously the demand for universal health coverage, as we speak about it, would provide a more coordinated approach to this, perhaps raise the question of compensation, reduce the overall costs on patients specifically, and the other social costs that we've spoken about. It's a complex problem without doubt, but our thinking is that if we elevate discussion and talk about the possibility of expanding the donor base, providing compensation, because compensation would be an essential incentive, to be honest. Someone is taking a very big one. And to begin to debate how that compensation could be structured, I think would be much, much more helpful to patients such as Ken on one side, and to their caregivers such as Dr. Cheptinga, In addition to Beatrice, who's also a renal care patient, going through patient in other parts. So we know that as we've had, the prevalence of kidney disease, I think, is going to rise based just naturally on natural statistics, changing lifestyles, the demographic profile of this country. And we better be prepared. And the IEA's view is to start this conversation today. We will harness as much information as we can. The presentations today, which have been fantastic, will be made available on our website soon after this. There'll be a link. In addition to some of the references that my colleague Maureen and Emmanuel spoke about, we'll make them available so you can continue. But yes, the IEA gives you the commitment that we'll continue to explore the mechanisms through which we can make public health systems work more efficiently. And we think that considering compensation and sharpening some of the efficiencies within the system would help, because as it exists now, if it takes 76,000 shillings at a minimum to cure one patient, the rate at which illnesses may grow and the burden that it imposes on patients suggests to us that both on the economic side, which is the fiscal solvency of the National Health Insurance Fund, which is the major payer on the one side, families as well will depend on the more efficient systems being found, and that is renal replacement therapy. So Dr. Kipkurui on the one side, and Ken, we're very thankful for all of you, Emmanuel and Maureen, and for the rest of you, thanks for being here and staying with us today. As for Ken, we continue to watch out for you. Please let us know in which other ways we can help. We hope that sooner than later, we'll be back here as we have this conversation on a daily basis, hoping that you'll have found, or rather, been advanced towards the renal replacement. And I think you need to keep that hope. Thanks for being here, and good luck, everybody. Have a good afternoon.
Good afternoon. Thank you.
Thank you very much.